Welcome everybody to our HEAL2 talk, Health Education, Awareness, and Literacy equals Healthy Engagement, Actions, and Life. We have medical doctors from Brigham Women's Hospital who speak to us on various topics on the first and third Thursdays of every month at 7 p.m. I want to thank you in advance for keeping your questions and your comments pointed and short as possible, but don't keep it too short if you need to get a point across. But remember that other people want to ask questions also. You can put your questions in the chat if you'd like to, and we will address questions in the chat. We are recording, so please keep that in mind if you do share something, that it is being recorded and will be available on Facebook later on for many people to see. Tonight we have Dr. Emily Moore, who Hallie Rosinski is going to introduce.
Yeah, so as Mandy said, this is Dr. Emily Moore. She is a second-year resident at Brigham and Women's Hospital in our internal medicine and primary care residency. And she comes formerly from Vanderbilt and UVA prior to that. And we are delighted to have her join us tonight. So Emily is very interested in primary care and primary care related topics, and is going to talk with us a little bit about sort of aging and conversations around that.
Yes.
And then before, I'm sorry, Emily, I forgot to mention, before you get started, I'd like to do the pre-poll, the pre-talk poll. So I'm going to bring up a poll, and if people can answer the poll, can everybody see that? Oh, okay, okay. Okay. So it looks like, of those who participated, that most people are somewhat comfortable starting a conversation about future wishes regarding care with loved ones. Half of us have a healthcare proxy, and half of us also have a personal plan regarding end-of-life wishes. Okay. Thank you.
Great. Thank you so much, Mandy and Hallie. Yeah, so I mean, before I share my screen, I'll just say that sometimes this is something that's really hard to talk about for people, especially it can just be really emotional, and people can have had really really personal experiences. And so I just want to recognize that this can cause a lot of strong emotions. And so my hope here is to talk about this in a way that is productive and, acknowledging that this is real and something that we all deal with or will deal with eventually, but can be less bad at times if we are able to think about it ahead of time. So I'll share my screen. Oh, Mandy, it is, I'm not sure that it's letting me share. It looks like just you are the host right now.
Try that.
Great. All right, are you all able to see my screen? Okay, fabulous. So these are the learning objectives. Our goals will be just to talk about some basic terms and definitions that are related to end-of-life care that we might hear in these situations. And then secondly, become familiar with options for personal advanced care planning. And then we'll have some time to practice out loud some strategies to talk with loved ones about what our future wishes are. And then at the end, we will get to some other safety issues in the elderly, and also just name caregiver burnout as something that can be a real source of stress for people that have an ill loved one. So the big term is advanced care planning. And so it's very broad. And basically it's like contingency planning. It's like making plans ahead of time for situations that might arise, and the things that I'm going to talk about are, what decisions are out there, and then thinking about what you would decide if those decisions came up. And then part of that too is who should decide for me, just in case I can't make that decision myself. And then based on what I've thought about all these things right now, who should know what I would decide in the future? And so advanced directive is a word that comes up a lot. And this is another slightly vague term. It's basically a document of your wishes for future medical treatment. And this can refer to a couple different things. It can refer to a living will, which in Massachusetts is not legally binding, but can still be a very helpful guideline for people if you filled this out. And then another thing is a MOLST form, which is legally binding, and that's filled out with a healthcare professional. And we, perhaps Hallie or us later, can provide links to some of these things just to provide an example. And I'll throughout this talk, I'll just say, your wishes for these things can change, and in fact, maybe should change as your situation evolves and as time goes on. So although it is legally binding at the time you complete it, it's only set in stone as long as you want it to be, and you can always change it. So power of attorney is something else that comes up often. So there are two kinds. There's a financial power of attorney, which deals with financial matters, things like paying bills, and can have access to bank accounts, things of that nature. And then there's a healthcare power of attorney. Another word for that is a healthcare proxy. And this person can only make medical decisions. Now, the same person can be both a financial and a healthcare power of attorney, but they can be two separate people. And these are documents that are filled out that are legally binding. So another term I wanted to talk about that comes up a lot related to end of life is palliative care. And so what is palliative care? Basically, it's a medical specialty and philosophy, and the focus of it is on treating symptoms. The focus is on improving quality of life, and the focus is on what is most important to the patient. And it can look different for everybody. And the main point is that it depends on what the patient's goals are. And examples of that may be if somebody's goal is to cure a disease, or if somebody's goal is to live long enough to see their child graduate, or if their goal is just to have their pain controlled enough that they can enjoy whatever time they have left. And things that it is not giving up to engage in palliative care. And it doesn't mean you can't get treatment to try to cure a disease. It just means everybody is different, and some people may not want that. And it's not only just for people who are close to death. It's actually for anybody with a chronic illness. Examples of that might be dementia, COPD, heart failure. It's typically for diseases that worsen with time and that we just don't have a cure for. So it recognizes that these are things that will progress. And palliative care can help adjust the things and the medicines and the overall care along the way as the disease changes and a person's life changes. And then hospice is another word that comes up a lot. So this is when we are much closer to the end of life. And this is when our focus shifts from curing a disease to treating symptoms. And this is done in a discussion with either the patient and their doctor, or a healthcare proxy and the physician, or other providers on the team. It's a collective choice, and it's usually that crossroads is come to when treatment is not helping anymore, or it's causing more harm than good. And an example that sometimes comes up that may, that that folks may have seen or heard about is cancer treatment or chemotherapy. So chemotherapy can help treat cancers, and sometimes they can cure cancers, but sometimes if a cancer is too advanced and or chemotherapy also has a lot of side effects that are really distressing and painful, and you have to be quite strong to go through chemotherapy because how hard they are on your body. And so sometimes if a disease is too advanced, folks might say chemotherapy is just going to cause more pain than it is going to cause good. And so technically the definition is for somebody that has less than 6 months to live without getting any treatment, like a chemotherapy medicine for cancer. And hospice can actually happen at home or a facility. And it means that it means that a nurse is involved regularly, a provider is always on call. It doesn't mean stopping all medicines. For instance, somebody can still get pain medicines and things of that nature to be comfortable. It just means you're not going forward with trying to cure something. Somebody can leave hospice if they want to. So somebody who originally thought, I'm tired of going through chemotherapy. I don't want to try to cure this cancer anymore. I just want to be comfortable. But then later on, similar to an example I said earlier, says, oh, my kid is going to graduate in 2 months. I want to be there for that. I want to get out of hospice and try to, pursue some of these treatments again. That's a viable option. And then if you live longer than 6 months, nobody kicks you out of hospice. You can stay as long as you need. And then
quick question, I'm sorry.
Yes, of course.
For the palliative care one, is that the one where you have other staff who are involved in your treatment, and that's the one that you're supposed to ask for? I just want to make sure I remember that.
Tell me more about what you mean, Dana.
One, because I thought I heard before that is the one where other doctors are involved, maybe in your care, who might not typically have been, but you have to know this and request it because it isn't automatic that the hospital is going to suggest this.
Yeah, great point and great question. So a few things. So palliative care is its own medical specialty. So you are right, there are separate palliative care physicians. And so usually those are extra folks that are coming in to join a healthcare team. And it definitely is something that can be requested by a patient or a family if particularly situations I think of that might arise are, if there's a lot of medical conditions or if there's a lot of specialists and a lot of medical problems, palliative care can sometimes be helpful to step back and help us see the big picture to make sure that all of these teams are coordinating in terms of doing care that makes sense for the patient, and that is we're doing what's most important to the patient. Sometimes it is the primary team that also thinks that, and we'll have that realization that, there's a lot going on and I don't know that all of this may make sense. And we need, it's helpful to have these folks on board who this is their specialty to help us think through what our next steps are. And that was a lot of words. So let me pause and see what other questions or follow-up questions do you have about what I said, or did that answer your question?
Yeah, sure. Yeah, that definitely answered it. But I was curious because you said dementia, Alzheimer's, those are cases where maybe you might have the palliative care team. And I'm kind of curious now as to what percentage of people with Alzheimer's or dementia are actually getting this additional care? If people aren't aware that this is out there and these are resources for them. I'm just kind of curious as to what percentage of people with maybe, I don't even know if you know the answer to this, but dementia or Alzheimer's who actually have this additional care. I'm kind of curious about that.
Yeah, that's such a great question. I don't have a number off the top of my head. Maybe Hallie, you might be able to do some digging as we go on about any statistics. And if we're not able to find any, we can follow up afterwards. Because from anecdotally, I don't think enough people are involved with palliative care. I think that it's something that can be really helpful in all of these situations. It's helpful to have a third party, and part of that is patients and providers don't always have the knowledge to refer to palliative care. I think also that there aren't as many palliative care doctors as perhaps there is a need. But I think that your question is a really good one. So we can follow up on that.
All right. So if I were to go to Brigham and Women, you're more likely to find a palliative team than if I were to maybe a much smaller hospital. You might not necessarily get all these extra things. Is that what you're saying?
That may be true. I don't know how common it is at non-academic centers. It's a good question. I can speak for the big academic centers in Boston that they have palliative care programs, but it's a great question. I don't know exactly how prevalent they are.
Okay. Thank you.
Oh, of course. That's a great question. Any other questions or thoughts at this point?
No, I mean, Emily, I love that you highlighted that it's for that palliative care is for chronic progressive diseases and not just diseases that are, near death. Because I think that's a misunderstanding that I hear a lot when we talk about palliative care. People worry that it means that we're saying that they're going to die, as opposed to saying like, we just know this isn't going to go away. And so we want to step in, early to start thinking about symptom management. So I love that. Yeah, that you clarified that.
No, thanks, Hallie. Anything else or any other thoughts from anybody?
Emily, so I'm quite, my buddy, Michael Ansberg, who, I had the pleasure of going to med school with, so I've known it forever. And, like me, a cardiologist who kind of finally figured out maybe something else matters. And I think that one of the things that's hard as a physician is, we get used to this idea that our job is to cure that disease. And there is this problem when, we sort of face the fact that, that didn't work. I've run out of the tricks in my bag, and the patient feels a little bit abandoned. And I've been impressed that this is where palliative care is spectacularly successful, because it actually lifts the spirits of the doc. As often as much as the patient realizes, there's a lot more we can still do that really matters. And again, I give Mike credit for sort of my education in that realm.
Fantastic. Thank you for sharing that. Any other thoughts from anybody about this? Okay. And again, just as Gaina did, please interrupt me as I go on. My hope is that this is interesting and, we can chat about it. So just to finish these definitions, we did finish the definitions. How convenient. So my goal next. So those are some big terms that we might hear come up a lot when we talk about things related to end of life care and these advanced care planning decisions. This picture right here on the slide is what a MOLST form actually looks like. And I actually want to walk through each of these decisions on a MOLST form. And I want to preface this again by saying, this may be really emotional and kind of if it's happened to somebody really near and dear to you. I also want to say it does venture into the more medical and sciencey side, but I do want to talk about it because I think that that's something that can be really intimidating for patients if you hear about all of this stuff for the first time on top of a loved one's critical illness. And so my hope is by bringing it up now, we can start, familiarizing with some of these things. So the first one is CPR. Whenever somebody is admitted to the hospital, somebody asks you, would you want CPR if there was an emergency? And sometimes they don't explain too much more beyond that. And so what CPR is, CPR stands for cardiopulmonary resuscitation, basically trying to bring back your heart and your lungs if they're not working. And CPR is specifically done if your heart stops beating. And so what it means is chest compressions always. So somebody pushes on the outside of your chest to try to pump your heart from the outside and then to circulate your blood through your body. CPR also involves medicines to try to help the heart start beating on its own again. And sometimes it involves something like defibrillation, which is another word for shocks from a machine. If you've seen in movies pads on a chest and attached with wires to a machine, that's what that is. But unlike the movies, it really doesn't work that well. It has a really low success rate. And for somebody that has their heart stop beating outside of the hospital, about 1 in 10 people, CPR might work in restarting their heart. And if you're in the hospital, it's a little bit better, but not much better. It's about 2 out of every 10 people it might work. And part of the reason for that is people that need CPR are really sick because, like we said, it's only done if your heart stops beating. CPR also has risks, like it can break ribs and collapse lungs because of how hard we have to push on chests to keep the heart going during this. And especially if somebody's really old and sick, that can be really hard to recover from. So any questions about that? Again, I know it was more medical, but any questions on that? Okay. And then next question that everybody that goes into the hospital is always asked is about intubation. Do you want intubation or not? And what intubation means is like these pictures here on the right. An intubation is when you put a tube down the throat and it extends all the way down here to the lungs, because the lungs are down here in our chest. I don't know if you can see my mouse, but I'm sort of gesturing to where the lungs are in our chest. And so this tube, this end of the tube will connect with a wire, which we don't see in this picture, but it'll connect with a tube to a ventilator machine. And that machine pushes air through the tube, which goes down to the lungs and helps somebody breathe who can't breathe on their own. And this is a picture of the ventilator machine. And these two things are the tubes and the wire. And you can imagine that this end of the wire would be longer and connect to somebody lying in a bed with the tube right here. And so the goal is once your lungs and your sickness get better and you can breathe by yourself, the goal is that we can take the tube out and you'll be able to breathe on your own. But again, if somebody is sicker, this can be hard to do because sometimes people's bodies are just too sick to ever be able to breathe on their own again. And so one thing I do want to mention is if somebody wants CPR, we do usually recommend intubation too, just because if somebody wants to give their heart the best chance of success, usually giving it oxygen from the breathing tube helps make that happen. And then another decision that we don't ask about every time somebody comes into the hospital. Intubation and CPR, we always ask when folks come into the hospital. These next couple come up at the end of life, but we don't often talk about them routinely. And so one of these things is called artificial nutrition and hydration. So what that means, artificial nutrition, it looks like baby food. And it looks like this, it comes in this bottle in this picture right here to the side. It's like a pureed mix of food. And it goes in through a feeding tube, in through the nose to the stomach. So this picture here is an example of a feeding tube that goes in through the nose. So you can imagine this wire right here connecting to the end of this tube. And that gives nutrition for people. And if needed for a long time, because you can imagine this isn't an ideal spot to have a tube. It's pretty annoying. It's hard to live your life and do normal things with it. If somebody needs it for a long time, sometimes a surgery can be done to put a tube right into the stomach to get food that way. And those are called PEG tubes or G tubes. And then artificial hydration. means IV fluids into a vein through a tube. So if anybody's ever had their blood drawn or had an IV, it's when they put a needle into your vein and then connect that with a thin tube to a bag of fluids. So you don't have to drink through your mouth. It just goes straight into your veins. And this is a picture of what an IV is. Oh no, go on, please.
How long is?
I'm sorry, I can't quite hear you.
I wonder if maybe she froze.
Yeah. I think she
Oh.
froze.
Okay. Does somebody mind typing in the chat that she froze and she can chat us her question? That may work.
Oh, can you hear me? I think I was frozen.
You were frozen.
Great. You
You're
were.
back.
Yes.
Oh, did you hear my question?
I did not. Please
Oh,
ask.
sorry. No, my question is, you said if the tube through the nose is in for too long, then they would have to do through the stomach. What is considered too long? Because I visited someone who had one through the nose. I was actually a little bit surprised that the person had it at all. But I'm curious as to what is that length of time, and it is too long where now it has to be in the stomach. And I think I have a follow-up question.
Yeah, that's a great question. To my knowledge, there's no precise time limit. Part of it is that it's less that it's harmful to have it in your nose that long, and more that it's just more difficult to go about your daily life with a tube through the nose. And so part of how we think about transitioning to a tube in the stomach from the nose is thinking about how long somebody might need it. And for instance, if somebody I'll give an example. If somebody has a throat cancer and needed surgery and radiation and to that area, it may be really hard for them to swallow safely for a really long time while they're undergoing radiation and all of those things until their surgery heals. That might be somebody who gets a tube in their stomach, which they might need for a year or two while they go through all of that. And you might imagine that having a tube in their nose for that long would just not be really helpful to go through daily life having to deal with that. But a tube in the stomach, you can folks may wrap a band around it to keep it in place, and it fits nicely under the shirt. It's very small and unobtrusive, and so it's just easier to go through the world with that. That might be an example. It's a lot of how we think of it is looking forward and thinking, how long might somebody need this?
Oh, so you can get enough nutrition for a year or 2 years just through your stomach? I mean, it just...
Yeah.
Huh.
Yeah. It's a great question, and it seems interesting, but these have a lot of nutrients in them, and everybody has a different feeding schedule. But sometimes when people are in the hospital, these feeds will be going 24 hours a day. And so you might imagine, if you compare that with someone who doesn't have this and is able to eat 3 separate meals a day versus somebody who's getting 24 hours a day of nutrition through this, they can actually get a pretty respectable amount of nutrition that way.
Okay. Oh,
I say just the only other thing I would add is I think when the tube is in your nose for more than 6 weeks or so, we also start worrying just about pressure damage, in the same way you would think of a pressure sore on someone's butt if they're in bed for a while. If the tube is in their nose for 6+ weeks, then we start to worry about pressure damage. That's another reason to switch sometimes.
Great. Thank you, Hallie.
Yeah. I don't know if I cut you off, Gaina, if you were to ask the question.
Yeah, I had another question that was slightly different because I'm curious, I was curious, say someone had maybe, I don't know, a stroke or something, why would they be on a feeding tube, especially if they're moving around? That is something that would surprise me. What would be going on that you would need that?
Yeah, that's such a great question. one reason that people who have had strokes end up needing feeding tubes is because sometimes it can decrease how safely you can swallow. So one reason, one worry in that sense is if somebody is not swallowing super well, for instance, if they swallow partially or food is getting stuck in their throat and they're coughing or choking a little bit, there's a risk of something we call aspiration, which is when food stuffs and water stuffs end up in the lungs and can cause an infection. And strokes can sometimes make it hard to swallow safely and puts folks at risk for those sorts of infections. And so sometimes it's safer to feed them through a tube like that.
Okay.
But okay, good question. Yes, what other questions? Okay, great, but lovely questions. Please keep asking them. And then just the last thing to say about artificial nutrition and hydration, exactly like what Gaina was saying, there's a few main reasons we use it. So one of them is if somebody can't chew. For instance, the example of somebody with throat or mouth cancer, they just aren't able to physically take in enough water and food to have enough nutrition. Another reason is if somebody can't swallow without choking, like the example of somebody with a stroke I gave. And then the other one is just somebody who isn't eating or drinking enough. So for instance, if somebody is in the ICU in a coma and just isn't awake to take in that nutrition, we can help give their body what the food it needs through tubes like that. And I will say that this tends to be less helpful towards the end of life. And what I mean by that is as folks get quite close to death, their bodies change in certain ways that make it harder to use the nutrition and hydration. Sometimes putting in feeding, there's actually studies that have shown feeding tubes in people with advanced dementia don't actually prolong their lives, and it can just increase suffering. It can make them feel bloated. It can put them at more risk for what we call aspiration, for that food to end up in their lungs. It can cause some harm as well. And so towards the end of life, we think really carefully about whether nutrition and hydration will actually be helpful. And usually the answer is maybe not. And then the other decisions that are on that MOLST form is, do you want to go to the hospital or do you want to stay at home if you get sicker? Sometimes this is really important to people because some people may say, I want to pass away at home in a place that I love, surrounded by people I love, and I don't want to die in a hospital. But some people say, if it's something that's fixable, I do want to go to the hospital, have them fix what they can, and then I'll go back home if possible, knowing that it is a risk that you take that might not be possible. Secondly, dialysis. So this word, you may know people that are on dialysis. And what that is it's if your kidneys don't work. Dialysis is basically a machine that helps clean your blood, because usually your kidneys do that. And if your kidneys aren't working well, a machine can help do it for you. And then lastly, non-invasive ventilation is a fancy word that appears on that form. What that means is CPAP or BiPAP. And you might have heard those before because you might know somebody with sleep apnea. And for somebody with sleep apnea, that is as I will say, it is confusing because it's the same machine. That is a very separate use for it than it is the use I'm talking about. So in the use I'm talking about, CPAP or BiPAP is actually a really good thing we can do in an emergency. It gives a lot of oxygen, and can help somebody breathe who's struggling to breathe, it's basically the best we can do besides putting that tube down somebody's throat, besides intubating. But it doesn't work quite as well as that, but it's one step before that. And so that's something that folks can decide on the MOLST form if they want that or not. Because sometimes people say, yeah, I don't want to be intubated, but I do want my best shot at, helping my breathing the best it can. Some people say, I don't think I want that. That's something that I would have to go to the hospital for. And if my breathing's getting that bad, maybe it's just my time. So that's something that everybody's they choose differently about. So
I have a question that
fabulous.
there's a question in the chat from Tony about what is the difference between the two. I think referring to CPAP versus BiPAP, but I'm not 100% sure.
Is that what you mean, Tony?
Sorry, yes.
Okay, great question. I would say for general purposes, they are almost the same. They're a little bit different in that CPAP, I think about as a constant stream forward of air. And no matter if you're breathing in or out, you just have this machine that is blowing air really hard into your face. In BiPAP, that takes into account, sometimes if you're trying to breathe out against all this air that's going in, it can feel a little weird and feel a little uncomfortable. And so BiPAP, when you breathe out, it lowers how hard the air is blowing in, just to make it a little bit easier. That's the only difference. Bi is basically there's two, so bi means two, and there's basically two levels of how hard the air blows. CPAP is C is for continuous, so it's basically one level blowing really hard all the time.
In your training, sorry, go ahead.
No, go on.
I want to make sure that was answered for Tony first before I say anything.
Sure, yeah. Tony, does that make sense? Any other questions about that?
No, that's clear. Thank you very much.
Okay, yeah, totally. And Gina, what's
my
your
question is, like, for your training, do you all get to like put some of these things on and experience it yourself, like especially if it's not going to cause harm, so that you can actually feel what a patient is doing, so that when you're doing things to a patient, you kind of like know also personally? I'm kind of curious if they let you try these things.
That's a great question. I personally have never tried these things.
Okay.
What do you think, Hallie?
It's a really good question. I think it depends just on sort of who there's. So I would say there's no like formal thing where everybody tries it, as far as I know. One of the doctors I worked with had us put on a CPAP mask to see just what that felt like. It's a lot of air. So I think it depends on just sort of who you're working with. I've had, like I said, like my whole group did it that time. I think some doctors will have you like try some of the supplements patients get and stuff too, to like see what it tastes like or see what it's like to have, like a kidney safe diet. But I think it's just a little bit of like chance. There's no formal system. We probably should all try it to have a sense.
Yeah,
because it feels almost as if like, like if you knew like how much air was actually coming through there and what the patient's actually feeling, that you end up being a little bit more sensitive to some person saying, oh my gosh, this is too much or whatever, that you have a sense as to what they're really saying versus this is supposed to be good for you, you're supposed to keep it on, that type of thing.
I think you're completely right. I think that's a really good point. Any other thoughts or anything on that vein, or I'll open up any other questions about any of these decisions that are are very common ones that come up. Okay. So I will pause here and just mention that there definitely are racial disparities in end of life care. And mainly how that manifests is folks that identify as a racial minority, particularly the data I looked at was folks who identify as Black or Latinx or Hispanic, when compared with whites, tend to have more end-of-life healthcare use. And that is a broad phrase, and some examples are, more likely to use dialysis, more likely to be what we call a full code, more likely to want CPR, more likely to want intubation, more likely to want all of these measures that we've discussed. Folks are also more likely to die in a hospital when compared with other places such as a nursing facility or at home. And then folks are less likely to have done advanced care planning, which was defined as, among a few other things, having a healthcare proxy. And I think, based on the reading I had done, there are a multitude of reasons behind these differences. And I think it is really complicated as are many healthcare disparities. But the primary one, which echoes across a lot of different disparities, is medical mistrust. And part of it is a worry that it will lead to worse or different medical treatment, which certainly has a basis in historical, mistreatment, experimentation, and abuse of folks who are minorities by our healthcare system and by doctors. And then part of it is thought to be from different available services. And what I mean by that is services available based on geography, for instance, knowing that folks in rural areas tend to be more white versus folks in cities have a higher percentage of minority populations. Another example of this is based on insurance discrepancies across demographics, as well as socioeconomic status and just a literal ability to access some of these services. Hospice is one that, from my personal experience, and I welcome, everyone else, I welcome Hallie's thoughts and Dr. Ritzker's thoughts, but my experience is that a lot of those services can tend to be dependent on how much you can pay out of pocket, which can be challenging for many folks. I think one other thing is just less aware of options. Sometimes that can relate to contact with the healthcare system, because we know folks who identify as a racial minority are statistically, some corners of those populations just have less access to healthcare in general. Overall, encouraging that disparities are narrowing, primarily around increased provider and patient knowledge of these things. So I'll stop there because I know that's a really weighty topic, and I want to see what thoughts you all have about this.
Emily, first of all, I have no idea who Dr. Ridker is, but Paul has a few thoughts on this. I think that you, I think an awful lot of this is fundamental mistrust, and that's understandable and kind of sad if you really think about it. Again, for the non-physicians on the call, there's another poll that Emily may want to talk about, which is that physicians themselves surprisingly rarely pursue a lot of things that we actually do to our patients. And I think that's telling. And that's not and I don't believe that's a socioeconomic issue or an access issue. That's just simply having seen it and watched it and sort of said, well, this is not for me. And I think that's very challenging to the medical profession to sort of recognize that some of the things that we do, we don't want done to ourselves is really a major tough way of thinking about being a physician and much less being a patient. So.
Yeah, no, thank you. That's very insightful. What other thoughts?
I think it's why conversations like this is so very important, because even like going back to like my original question with the palliative care, even like knowing that, so that if you're in a situation, I know that my grandmother passed away from Alzheimer's a number of years ago. But, just knowing that these are additional things that you could potentially ask about, is great, because thinking back on it, I'm not sure that if we actually had that, or if we did, like, would I have like recognized it? Because I wasn't really aware. But now, like, this is something that would be in my mind. So I think conversations like these are important, because we become aware of like what is out there and what we could potentially ask for.
Yeah, thank you for sharing that, Dana.
And to follow up on that, Kena, as well, like, I think some of what's so hard about the like advanced care planning that Emily was talking about is that, it asks us to take a time when we like feel fine or feel mostly fine and think about what could happen if things go like very wrong or we get very sick. And it just requires a lot of like planning and a lot of advanced thought. And I think, in the moment, people often make very different decisions because they're scared or nervous, for many reasons, than they might if they sort of sat and thought about it. And so I think, just to your point, if we're sort of not empowered to like know what the options are ahead of time and know like what kinds of questions you might get asked, it's just so hard to think about what you would want, if it's like a spur of the moment thing versus like, versus being able to see ahead.
Yeah, thank you. What else? What other thoughts? Okay, well, thank you all for sharing. I know, again, this is can be hard to talk about. So, like I said, overwhelming. So, what next? I think now, I want to be respectful of everybody's time, and I think this next part will not be nearly as information heavy as this first part. My hope is that we can practice either with each other or privately how to talk about some of these things, because I think how to even start talking about them and thinking about them can be really hard. So one thing I just want to say is the Conversation Project is a fantastic resource that I think is, it's accessible to everybody. It's not geared for doctors, it's geared for patients. Patients as in all of us, because we all will be patients at some point in our lives. And so the first part of the Conversation Project is thinking about, what do you need to enjoy your life? And what that means is, do you need to be around family? And that's really it. One other consideration, do you need your independence? Do you need to be able to walk outside, get your own groceries, live your own life? Do you need to be independent? Another example could be, do you need to attend a certain event at this point in life? And, that's your goal, and that's what, you're really shooting for. Those are examples of what that question might mean. And then step 2 is, what do you want if you get sick? And like Hallie says, it's hard. It can be really hard to think about that when we're well, but really thinking through the specifics of actually all of these things that I've shared, and in terms of the decisions that are out there, can be really important. And more broadly, I would say, in terms of what you want, things that I might think about that are perhaps easier to grasp or wrap our heads around are, are you somebody that wants to know a lot of things about your medical condition, or are you somebody that wants to defer your health in those sorts of big decisions to loved ones or to the doctors? Are you somebody that wants to, really try everything and have know that you did everything possible? Or are you somebody that says, you know what, enough is enough, this is too much, and I would rather be home? Or, those are just examples. And then the last part of it is, who should know these things? And by that, I mean specifically doctors and loved ones. So these are just really big questions to ask yourself. Your most important goals if your health situation worsens. like what we've mentioned before. What are your biggest fears and worries about the future with your health? For instance, I won't be around to see my grandkids grow up, things of that nature. What gives you strength as you think about the future with your illness? My partner is really supportive, or I know I'm strong, I could get through this. What abilities are so critical to your life that you can't imagine living without them? For instance, going for a walk and enjoying outside. And then if you become sicker, how much are you willing to go through for the chance of getting more time? And then how much does your family know about your priorities and wishes? And then talking to your doctor, because they know you, they know your medical conditions, and so they'll be able to shed light on how that might play into some of these decisions. And then your loved ones, because they know you, and they may also be able to shed light on some of these decisions, but also they may be the ones down the road making those decisions. So these are examples of how you might talk with somebody that you love about these things. And these are 6 examples of phrases that we could use to literally start the conversation, because sometimes it's really hard to talk about something like this that's really weighty. And so I think it's actually helpful to have a phrase in your brain to do it. And so what I actually want to do is leave this up for about a minute, 45 seconds. And I think everybody's pretty much muted, but you can even turn your camera off if you want to. But I just want you to say one of these out loud to yourself, just so you can hear the words coming out of your mouth. And then we can come back in a minute or so and see how it felt. So I'm going to do it too. So I'm going to turn off my camera and mute myself. Okay, I want to bring everybody back. I know that wasn't too long, but I'm just curious about if anybody feels comfortable sharing which one they picked and how it felt actually saying the words. And I can start. I picked this second one. I'm not really fancy. I'm pretty bare bones and direct. And so the thing I said was, hey, I was, hoping that we could talk about what might happen if I get really sick.
I had to have this conversation with my family when my mom got sick, and I needed to let them know that I was signing her up for hospice care. And so now, as a result, every time I try to start the conversation with my family, they're like, nope, we're not doing it, not ready to have this conversation, not happening.
Yeah.
So I haven't quite figured out how to get them to engage with me when they kind of see where it went with their grandmother.
Yeah. Tony, thank you for sharing that. That's such a hard thing to deal with, and there's nothing easy to say about it. Does anybody have any thoughts or ideas, or if anybody's dealt with something similar that they don't mind sharing?
Emily, I think one of the really hard things about this, and again, I want to thank you you guys for covering this tonight, is that particularly for the younger physicians, most young people blessedly haven't had a major illness, and really until either you've been sick yourself or a spouse or a child or someone incredibly close to you goes through a major illness, or a parent passes or whatever, you just really don't cognate any of this. It's the difference between empathy and sympathy. And I think that, I don't wish a major illness among everybody in training, but if I could give them something that I knew they'd recover from, it probably wouldn't be a terrible idea. I mean, it's just very interesting to me to think of the things that, I don't know, I want to read what Mandy thinks too, from a nursing perspective, but things that I did during my early physician years that just strike me as really, well, that was, I don't want to say naive, but well, probably naive is probably the right word. Whereas I think at a certain age, you go, oh, we only have one shot on this thing. And there are things I really do know what I want to do. I really do think I have. And so I have had these conversations with my parents who are now, closing in on 90. But I probably wish I'd had those conversations with them when they were closing in on 60, which is what I am. And I think it's just very interesting how these life cycle things work. And it's very hard when you're, in your 30s.
I have a couple different aspects. When I was very young, I worked in a trauma unit and we had a very high death rate. So we saw a lot of this decision making, how much treatment and when do you stop treatment, that kind of thing. But now at this stage in my life, 3 of 4 parents have been in hospice, one at my house. And it was actually a really wonderful experience because, my husband's a physician, I'm a nurse, we were able to medicate as needed and to have that special family time. So we have some funny stories and some touching stories, and it was very wonderful to have it.
Thanks for sharing that, Mandy. Any other thoughts or reflections about this?
Well, the sentence that came to my mind was the third one. I was thinking about what happened to blank, and it made me realize, I think that was the one that grabbed me more so, because I think you can connect more so with people when, here's some person, that you both know in common, and you're seeing this thing happen and you realize, oh my gosh, it can happen to anyone, and then you can go on from there. So that was the one that caught my attention more so. But it is definitely tough because, you don't necessarily want to think about these things, but, you really have to. And, and it's making me think more so about maybe not the living will, because you said it is not legal in Massachusetts. I'm not sure what is Massachusetts, one of the only places it isn't, or it just really isn't legal most places. I don't know.
It's hit or miss.
Oh, okay. But, some of the other things, there are things that I really need to sit down and think about. So this conversation is good because it's going to be forcing you to do that. So yes, I definitely have to think about it so that I can be in that percentage of the people who actually did it. Like Mandy did a poll at the beginning. But yeah, it's very important.
Yeah. Thank you for sharing that, Gina. Other thoughts or reflections? Okay, and I do want to get to Tony's question or thoughts in the chat as well. I have a little bit in the upcoming slides that may speak to that. I think, like Tony was saying, this is really hard, and especially she hits on those last two. Your loved ones might not be ready to discuss it with you, and your loved ones, even if they do discuss it with you, they might not agree with what you want for yourself. And so those are really hard, and I don't have anything easy to say about this. The main thoughts that this conversation project brings up, and that I have practicing in your head ahead of time can be helpful in terms of these phrases that, you know, we've just practiced ourselves. You know, practice how you start it can make it go a little bit easier and be less nerve-wracking. And then starting small, and what that might mean is starting with one specific decision. You know, you don't necessarily need to talk about all of these things at one time, but just saying, you know, hey, I was thinking about how when this person died in the hospital, and I really don't want to die in the hospital. I really want to die at home, surrounded by people that I love. That might just be a sentence that you say, and that might be all. But that's a really good start. And then another thought is starting small in terms of who you talk to. And so one thing that may be helpful is thinking about who you may want to be your healthcare proxy, you know, who you may want to be that one person to make decisions for you, and just tell that person. You know, it can be really hard, like Tony was saying, to tell, you know, multiple people at once, and then it can be just, you know, you're superwoman, this won't happen, none of us want to talk about it. But it can be perhaps more simple if you reach out to one person ahead of time and prepare them that you want to have the conversation and set the scene ahead of time. An example perhaps of words that you could use is, hey, you know, I want to talk about this later today. Are you free? And that may set the scene and is perhaps one way that could change things. So I'll stop there. Any thoughts on all of these things? Again, just ideas, you know, not one thing works for everybody, but just different strategies. Okay. So that is the last part on how to have those conversations yourselves and with your family. And then just to wrap up, because I know we're about at our end, just to name, these aren't decisions that come right at the end of life, but are just things to think about that come along with aging in general. And some of those things are related to housing, thinking about what if there are stairs and how mobile and how able to get around your loved one is as they get older. Thinking about your specific insurance and figuring out what services and facilities specifically they might cover. And that's something that often your doctor can help work with you for. Often, for instance, my clinic has a social worker in it, and they can be so helpful in figuring out what services you might be able to get to support you and your loved one. And then this next one is your resources in terms of money and family support, which is really different for everybody. And, you know, things like that, things of that nature might mean, is somebody available to stay home to care for this person? Do you have money to hire somebody to do that for you? Things like that. And then lastly, what I mean by the option of advancing tiers of care is there are facilities that sometimes you can start off in independent living, which is more of an apartment situation. And then once you're in the door, as their care needs progress, they may be able to move to assisted living with more supports, and then to nursing care with much more intensive supports as their needs change. And then another important thing is food. You know, we know as we get older, it can be harder to cook safely, and we know it can be harder to get groceries. And so again, you know, this is different for everyone. And so your doctor is the best resource for this, but supports such as home aids and programs like Meals on Wheels can help with both. And then these are two other resources that one of our geriatricians suggested. This last one is a little bit more geared for physicians, and so, but it, you know, can still be a helpful resource to look through. And then this top one is accessible for everybody. And then just to talk about caregiver burnout. So this is something that if you're caring for a loved one who has an illness like this that's approaching the end of life, we know that people that take care of those people can have caregiver burnout, which means basically a state of physical, emotional, mental exhaustion. And because it's really emotionally taxing to do this work. And so preventing it, making sure that you take care of yourself, eating well, exercising, and sleeping, they sound simple and trite, but they make a difference. And then I think secondly, an important thing is that negative feelings don't make you a bad caregiver or person. You know, having feelings of frustration toward your loved one, things of that nature don't mean that you are bad. It means that the situation is hard, and that's normal. And secondly, the thing to say is get help, because there are resources for caregiver burnout. There are respite programs, there are adult daycares, and again, they differ based on your insurance and the resources you have available. So talk with your doctor and therapists, social workers, other caregivers around you to get the help that you need, because there are supports out there. And that is all that I had to say. So I just wanted to pause and see if there are any reflections from anybody, particularly on the last part, you know, the latter part of the talk in terms of resources that come with aging and caregiver burnout.
Good question.
Yeah.
So do you just Google healthcare proxy and then multiple proxies come up and then you just like pick one? I'm kind of like curious as to, okay, like
The forms you mean?
that type thing. And also when you fill it, I imagine it's going to be kind of lengthy and it's probably going to take some time. Like, is it something that you're going to have to get like signatures from doctors and signatures from other people? And do you have to have a lawyer involved? I'm just thinking about like the logistics of it. Now we've talked about the importance, like would all those things be involved, or you're going to have to find a lawyer, have to get signatures from get the different doctors and everyone? Is that
such a great question? So in the things I can speak to, financial power of attorney, I cannot speak to as much. That may be more complex with lawyers. I don't know, but the healthcare, you don't need a lawyer, it's actually very easy to do it. And Hallie has just put in the chat the Massachusetts healthcare proxy form, which is you basically fill it out in the presence of two other people with your healthcare proxy, and then everybody signs it, and that's that.
Oh, so that one is just saying this person has
yeah, exactly.
But what about if you want to say specifically, I do not want to be on, say, a ventilator, I don't want this, like all those little things, like where does all that come in?
Great question. Yeah, great question. So how I would logistically think about these things. So a healthcare proxy form, you can either print it online and bring it with you to your doctor's office in the presence of your healthcare proxy, and then you can sign it there, for instance, during an appointment, or often doctor's offices will have them available. Regarding the other specific decisions regarding things like CPR and intubation and fluids, etc. So that is all in the context of a MOLST form, if you want it to be legal. And so that is also one that has to be filled out with a doctor present. And so that would be something that you can either fill out at a doctor's office or inpatient while you're admitted to the hospital. An advanced directive, since it's not legally binding, can be filled out at any time. Does that answer? What else can I answer about that?
Sure. No, I was just trying to figure out, like the logistics of it. Now that we've spoken about it, if you're advising someone to do this, like these are the things you need to do. And then it almost seems that if you are not sick at the time, you probably need to make an appointment with your doctor. And would your insurance cover it, because you're not necessarily coming for whatever, you just come in so they can find the time to sit with you to do this?
It's a great question. I would, if I had a patient that needed a MOLST form, I've never had any issues with insurance, I would just say. But I would probably, it often requires multiple conversations also. Sometimes it can say, you can let your doctor know ahead of time, hey, I want to talk about these things. Can we make sure to make time at our next appointment? Or, in the midst of a clinic visit, you can also let them know. Sometimes it takes more than one day to talk about these things, but it can be done in a doctor's office, yes.
All right, great, thank you.
Yeah, great question. What other thoughts or questions? Okay.
Emily, I would just say on behalf of Sportsmen and all of us, thank you so much for taking on a rather complicated topic. These are all recorded, and I am certain that this will get watched by the folks who watch our recordings. And thank you for doing this. And thanks, Hallie, for helping to run the show, and Mandy for getting this done, and everybody. So very, very helpful.
Thank you.
Great.
And
Awesome. Well, thank you all for coming.
Before we all leave, I have a poll for post poll. Let me see if I can get it up here. Okay, it should launch now.
Yes, and as folks are filling out the poll, I do want to say, it's all of these decisions are very individual and everybody decides very differently, depending on their life circumstances. And so, none of this talk is intended to help to, lead you towards one decision or the other. It's more just to share examples of how some people might think about these things. So again, I would just emphasize, talk with your loved ones and your doctor about your situation.
So I'm going to end the poll, and it looks like it was a huge success because ahead of time, many people said they were somewhat comfortable, and now we have 100% saying that they would be comfortable initiating the conversation. So that's wonderful. Thank you very much, Emily. I plan to healthcare proxy. Half said yes, and half already have one. And I will make a personal plan regarding my end of life wishes. Half said yes, and half said they already have one. And then the last question I had to ask was about staying on Zoom or getting back in person. And one person said they'd stay on Zoom, and then the other 75% said that they would like to choose between Zoom and being live at Sportsmen. So thank you. Yeah. Thank you.
Fantastic. Thanks, everyone.
This is great. Thank you very much.
I want to say that in 2 weeks, we'll have a talk on lung disease with Kelly Schuring, and she's going to talk on lung cancer, COPD, and asthma, and some of the racial differences with asthma too. So thank you very much, everyone.
Thank you, everyone. Really appreciate this.
Thanks. Bye.
Bye.